So I'm Dr. Christopher Domes at University of Wisconsin Medical Center, and I'm joined by Dr. Bruce Sangeorzan out of University of Washington and Harborview Medical Center. And we're here to discuss his paper from 2000, Outcomes After Open Reduction and Internal Fixation of lisfranc joints. So I'd like to thank Dr. Sangeorzan for joining us, and thank you for all your contributions to the AO over your vast career.
Well, thanks for the invite. It's a pleasure to be here.
Yeah. So we'll start off with some questions about your paper. When you guys started this and started looking into these patients, what was the real reason for looking into open reduction internal fixation of the lisfranc injuries in your group?
I think the main driver was we had a fellow who was interested, and it was about 10 years since Craig Arndt's initial paper using rigid fixation. One of the drivers for me to do a foot and ankle fellowship after my trauma fellowship was a case I had as a chief resident that had multiple dislocations within the midfoot. And I pulled open the standard journals and the standard textbooks and found nothing at all. And I think the majority of people in those days were just putting a cast on or putting a couple K-wires in. So Craig Arndt's paper with Dr. Hansen was a game changer, but it was a relatively small series and didn't have real long follow-up. So Rod Quo and Christy Giovanni, who were both terrific fellows, 1 foot, 1 trauma at the time, decided to put their brains together and look these up, see if we could find anything worth driving a conclusion. The secondary issue was that I had a high-profile patient who worked in the School of Medicine and who was 6'6" and had a pure ligamentous disruption of his lisfranc. And his other limb was impaired from childhood disorders. That was his only good limb. And we fixed him with screws. He had a size 13 or 14 shoe. And we fixed him, we used 3/5 screws. We didn't have 4/0 screws in those days. And I took the screws out at about 5 months and the foot collapsed. So we had this initial cue, should we be treating these pure ligamentous injuries differently? Those were the primary drivers.
Nice. You had previously written really on salvage. I think in 1993, you wrote a salvage paper on lisfranc, so it definitely has been an issue. So based on your paper, what are, in your words, the most important findings?
So I think first addressing your comment, the lisfranc salvage paper, of course, was written because people weren't doing a good job treating them. So we knew we wanted to improve the outcome. And we knew that we could fuse them if we had to without significant consequences. So that added to the mix. I think in all honesty, we didn't find much of value by contemporary standards. This was an observational trial. We didn't apply rigorous standards of reproducible measurements, and we didn't use a very psychometrically balanced outcome score. The AOFAS score has subsequently been shown to have a lot of bias built into it and a Monte Carlo style that makes it hard to really detect sensitive differences. So I don't think we're able to really give a large, or at least an evidence-based response. We did find, as we were expecting to find, that the pure ligamentous injuries did not do as well. And that's probably because ligaments don't heal as well as bone. And if you're depending on just ligaments, you probably need a little bit more support. And it further suggested that getting them anatomic was a good thing for the patient. So those were more backing up prior studies than they were new findings.
And in your paper, in the management and your protocol, you guys don't really discuss screw removal after the open reduction internal fixation. Was that the standard of practice at the time? If so, when was that usually done?
It's a very good question, and I have to put it in historical context because I don't think we had a protocol at the time. In general, we used flexible fixation to fix the 4th and 5th metatarsal, which we pulled at 6 weeks because we want the lateral border of the foot to move in the sagittal plane. The 1st, 2nd, and 3rd, which is known now as the medial column, has to be rigid, otherwise the medial part of the foot collapses. So we typically put the screws in there a minimum of 16 weeks, and we reassessed at that time. Were they symptomatic? Were they loosening? Were they broken? And made the decision to remove them based on that time frame, the 16-week time frame.
Gotcha. So normally 16 weeks for potential removal at the soonest.
And I would say we were removing less than half of them at the time, and that's probably still true.
Okay. And you, in the paper at least, it discusses the post-operative protocol, which included about 6 weeks of splinting and casting, and then a progressive weight-bearing plan after that. Is that currently still your protocol for these injuries, or have you altered that in any way?
I think it's still fairly true that in those patients where there's pure ligament or primary fusions or a mixed ligament and bone, we're generally keeping them non-weight bearing for 6 weeks. I give credit to people who are using the new plating systems that have orthogonal fixation, who are trying to weight bear people earlier. I think there's great potential benefit there. We haven't moved in that direction, I think, in part because those systems are expensive and there's an element of uncertainty there. And as a senior person who's seen a lot of stuff fall apart, I would rather sacrifice a few weeks of non-weight bearing on the front end than have to redo it in 10 or 20% of the cases.
Absolutely. And really, in the 22 years essentially since this paper was written and has come out, how have you seen your practice of lisfrancs change?
I think we do a lot more primary fusions than we did in the past. And obviously, that's a somewhat controversial concept. There are people who have shown a higher rate of revision in ORIF versus fusion. Those studies aren't strongly powered, and they count hardware removals, which is a decision rather than an outcome. And there are people who advocate in the other direction and feel that if you fuse those joints, you're creating problems. And then there's Chris Cossia's view that if you don't take the screws out, you're fusing them whether you think you are or not. My own bias is that large people with long feet that have pure ligamentous injuries, particularly those over 40, those get a primary fusion for 1, 2, and 3 in my book because the risk is low and you're likely going to have to get them stiff anyway. For less large people, it's probably not as important. And for young people, I'm a little bit nervous about fusing the midfoot in a 20-year-old, although we do that in bunion surgery on a fairly regular basis. So I think the jury's still out, and there's a lot of variation, so a surgeon can make his or her own decision about that. I lean toward fusion in bigger, older patients and away in the younger patients, and don't bother at all in the fractures that are more fracture than dislocation, because bone heals better than ligament.
So in the highly comminuted lisfrancs, you're just still screw fixating them or bridge plating them and not removing any cartilage?
Right. If the ligaments are still attached to the base of the metatarsal, then I feel confident that once the bone heals, I'm not going to have to worry about stability at the joint. So those comminuted ones, as you reference, are probably in that category.
Mhm.
And the bridge plating, I think that's certainly become a lot more common in the last 10 or 15 years. And it certainly helps with those that have metaphyseal missing bone or subluxation in that region. But those almost always have to come out just because the size of the implant relative to the padding in that part of the foot bother patients when they tie their shoes. So they're very useful when they're indicated. They just require a second operation.
Mhm. And then, is there anything else that you think this paper highlights that you would like to cover?
I think in a negative way, this is old literature. We did descriptive findings. We had a single person measuring. We weren't careful about what outcome measures we selected. I think for a young person early on, they want to do a better job than we did. They want to start entering the data at the time of the injury into their electronic medical record. They want to embed in their electronic medical record a more responsive and psychometrically appropriate outcome measure, whether it's the FAM for the foot or the MFA or the short form MFA, something we know works to measure outcomes in patients. And x-rays, of course, have to be measured by more than one person, and you have to compare those. Those are all things we didn't do 23 or 24 years ago when we were doing this, and those are really a requirement now. This kind of paper gets you onto the first step of the ladder, but it doesn't help you progress to the top of the ladder.
Yeah, still, it's, as we look back, this is one of the biggest, or at least patient number wise studies that we have for outcomes of Liz Franks, really due to how uncommon the injury is. And as we look at this series of webinars, looking back at papers that kind of help drive things, it's good to see where we were and kind of what from there has led us to where we are now. And we thank you so much, Dr. Sangeorzan, for taking time to join us on this webinar, and for continuing such a great career with the AO, and all your help and all your teaching that you've done for myself personally, and then also for everybody else who's benefited from your vast experience.
Thank you. Great pleasure to be here.